you for having me here today. My name is Catalina Costa. I am completing my pharmacy residency program at the Memorial Health System. I started there at the end of June, so I'm into my 90 days now shortly. I'm very happy to be here today because many of you may not know this, but I'm actually a NOVA graduate. I went to pharmacy school in Fort Lauderdale, and I graduated just this past May. So I'm happy to share this development of myself as a new practitioner, as well as the development of an upcoming PA. Today we're going to talk about the principles of pharmacotherapy in geriatrics. I do know that you covered some pediatrics recently, pharmacodynamics and pharmacokinetics. So I'll briefly touch upon those things and how it relates to geriatrics. So my goal is to be able to provide some takeaway points for you to take with you when you go on your practice rotations, and also provide you enough information to get all my test questions right. I just submitted those yesterday, so. I marked some slides to focus on when you're cramming, in the middle of the night. I've been there, so. So let's go ahead and get started. I have 5 objectives for you today. This is an overview of them. I will cover them individually as we get through. So let's talk about numbers. So elderly numbers. In 2013, we had about 44 million elderly people, defined as people greater than 65 years of age. That's about 1 in 7 Americans. And if you look into the future, in 2060, when I'm part of that generation, there will be 98 million. That's double the amount of elderly people. So why do you think this is occurring?
Population
Pharmacology, yes. Very good. Not only pharmacology, but we also have surgical interventions that prolong life. And there's also increased awareness of healthy eating, diet, lifestyle modifications, exercise. Any other things that come into mind? Thought about maybe genetics, passing down the genes. So I have a question for you. What is the average number of prescriptions consumed per year by an elderly person greater than 65 years of age?
C.
I hear C, and I hear D. All right, very good. So the answer is D, actually.
Wow.
But this is actually stratified. Those persons that fall under the 60 age category, they're the ones that consume 14 range, and then when you get up in the 80s, then you're looking at 18 prescriptions per year, and that's a lot. So why do we care about all of these prescription medications? Well, medication-related complications lead to confusion, falls in the elderly, depression, so they basically lose their independence. They're at increased risk of being in and out of the hospital, and when you look at the more you pile medications on there, the more likely they are to have an adverse drug reaction, and that will cost all of us. We somehow pay that over $100 billion per year. I don't know what I would do with $100 billion. All right, so let's talk about our first objective. Recognize the factors that place the older adults at risk for medication-related issues. So some of the risk factors are listed here. I think these are the major ones that we will touch upon: adherence issues, multiple or high-risk medications, as well as biology of aging, and multiple and advanced disease states. But before we get into talking about each of these, let's talk about some prescribing. The process of prescribing, which is exactly what you're going to be doing, is very challenging because you have to pick and figure out whether or not medication is going to be indicated in this population. And if it is indicated, then you have to pick from a bunch of available agents to treat that condition, and then you have to determine the right dose and the schedule. What's the problem with dosing in this population? Does anybody know?
Their liver function isn't as good, their kidney function's not as good, so.
Exactly. But if you look at the evidence-based literature, where do you think dosing comes from? What type of people? Healthy young people. They often exclude people, elderly people from clinical trials. So a dose that's appropriate in a person like myself may not necessarily be appropriate for someone aged greater than 65. And then if you do end up getting that drug at the right dose and the right schedule for them, then you still have to figure out, well, is this working? And does my patient know what side effects to look for and what toxicities to watch out for and tell me about them? So let's look at adherence. What is medication adherence? What is the definition of that to you? So taking medications on time, taking the right
As
drug,
prescribed.
the right amount, right? So it's not just taking the drug, period. And how does adherence differ from compliance? It's sort of a trick question. So it's used interchangeably in practice, but the major difference is that compliance is when you guys or us, the clinicians, play a paternalistic role to the patient and they just do what you tell them and they don't even know why. They just take it, live at the bottle. While adherence, they're actually an active member of their medication and they know that they're going to get better and they know why they need to take the medication. And so having adherence is very important because you need to have your patient involved. So what factors do you think contribute to medication adherence issues? Education, very good. Anybody else? Mental status, oh, that's very good. Oh, we're missing a very important one. Money. Prescriptions are very expensive. And if you think about this population, they probably are under Social Security, they have a fixed income, and a lot of medications are branded still, unfortunately. And they're going to have Medicare Part B insurance. Has anybody known or seen it or known or heard about the donut hole?
Yep.
So tell me, what's the donut hole mean to you?
There's a spot when Medicare pays for their prescriptions to a point, and then they stop paying until they reach another point in price per year. So I don't know the number, but there's like, they'll pay for like $500, and then from $500 to $2,000 they won't pay for, and then over $2,000 they'll pay for. I don't know the
Exactly.
exact numbers, but
The numbers vary per year too, but it runs around $3,000. So what happens is the patient has initial coverage. They'll pay for a percentage of it, and then the patient pays about 20% out of pocket. But then when the plan and the patient have reached a maximum limit, then the plan says, no, I'm not going to cover as much as I'm covering now. Now you're going to have to pay out of pocket, and you have to reach, I think it's like $7,000 out of pocket before I kick in again. So if you think about that, and you have a patient on regimen for the rest of their life on a very expensive medication, they're going to try to ration their medication and cut their pills in half, and so that leads to incorrect usage. All right, so other things that contribute to adherence issues are environments such as TV commercials. I want to share one of my favorite ones.
You may think some prescription NSAID pain relievers like ibuprofen and naproxen don't have any cardiovascular risks. But based on the available research, that's not clear. And if you look closer, the FDA requires all these NSAID pain relievers, including Celebrex, to have the same cardiovascular warning. Any prescription NSAID, including Celebrex, may increase the chance of heart attack or stroke, which can lead to death. This chance increases if you have heart disease or risk factors for it, such as high blood pressure or when NSAIDs are taken for long periods. All NSAIDs, including Celebrex, also increase the chance of serious skin reactions or stomach and intestine problems, such as bleeding and ulcers, which can occur without warning and may cause death. With any of these medicines, patients also taking...
All right, so what word stood out for you? Death. Anything else? Bleeding. Ulcers. Skin reactions. So, if your patient's taking a medication and they see that on TV, what do you think they're going to do?
Freak out.
They're not going take it. They're like, forget this. So these are the barriers that we have to deal with, and then you guys will have to deal with. You'll have so many patients come to you and say, you know what, I read that this medication causes death and I'm not going to take it anymore. So my job as a pharmacist is to go and educate them to ensure that before they leave the hospital, they understand why it's important that they do take their medication, even though it does have those side effects. And then of course you have so many multiple providers available that can lead to mismedications as you transition from one physician to another, and social embarrassment due to unpleasant side effects like flatulence, for example. Inconvenient dosing. Have you guys reviewed the Latin abbreviations yet?
Yeah.
What's QD versus QID?
Every day versus
Every
4 times a day.
Versus 4 times a day. So in the outpatient setting, you will see this written out, or you probably write it yourself. In the hospital, we don't see that much. But what I'm trying to get to is, if the patient has to take something 4 times a day, they're not going to do that. They'll forget it about 50% of the time. And then feasibility. I brought something to show you. And this happened to me personally. I've been in the pharmacy world for about 8 years as a technician, then as an intern, and now as a pharmacist. I had a patient come up to me and tell me, she placed this on the counter and she's like, I don't want to take this anymore, I want my money back, this isn't working for me. And so I asked her, well, what's going on? She's like, this is not working, I don't like it. So then I told her, tell me how you're taking it. She grabs a pill, opens it up, puts one in her mouth. And I'm like, that's how you're taking your medication? She's like, yeah, it's not doing anything. So, Spryriva, you guys have never seen it, it's an inhaler, long-acting beta, or as they call it, it's a cholinergic actually. And it requires you to open it, so you gotta open the top lid, then you gotta press here and open this part, which is kind of hard. You have to open the blister pack, put the pill in, close this back on, then the patient has to inhale and wait for a whistle sound. And then at that point, the powder is in their system. Sometimes they don't wait until the whistle, and so they never even got the medication. But the patient didn't even get to that step. So I'll pass it around so you guys can see how it works. But think about the feasibility of this medication in someone with Parkinson's, for example, trying to open a capsule. And you're more than welcome to open the capsule and take a look. They're placebo, it's okay. Don't take one. And then other things like childproof caps and pill sizes are others. So let's talk about multiple or high-risk medications. So polypharmacy is a term used to describe either the concomitant use of multiple drugs or administration of more medications that are indicated. And what causes this inappropriate prescribing? Multiple disease states. The more disease states you have, the more medications are going to pile onto you. And then having multiple providers, which we touched upon. So we need a lot of primary care providers. There's a shortage. And we as pharmacists are trying to expand our role in order to fill that gap. All right, so why does polypharmacy occur? It is thought that it's due to the prescribing cascade. So you have an adverse drug reaction from the medication that was prescribed. And so then they go and see you, and then you think it's some sort of condition, and you prescribe a new drug to treat this new condition, and then now the patient is at risk for developing more side effects. Has anybody experienced this? Or a family member that this has happened to? Can you share with us?
Sure. My mom's actually a pharmacist, so one of her good friends was taking it. He was something for blood pressure and then something for, I don't know, maybe it was gout or something, and they were, I guess, crossing over, and she didn't know he was taking it. He was just really tired, and he told her what he was taking, and then she found out there was like a cross, I guess, reactivity, and that's why his heart rate was slowing down. He had to go see a cardiologist, and it was just like a whole big mess after that. So.
Well, can you imagine if it wasn't even caught? They would have probably put him on some sort of medication to treat that side effect.
The doctor didn't even catch it. My mom's the one who kind of like told him to ask the doctor about it. So, yeah.
Very nice.
Right?
That's what we're here for, to catch these things. So in order to prevent the prescribing cascade, first you want to make sure you start low and titrate slow the original medication to avoid these side effects. And then also balance over prescribing and under-prescribing. Like, what does that mean? How can you really do that? It's hard. So the best way is to look at each drug and make sure that it's fulfilling that indication and that you are adequately managing that specific indication. don't be afraid to de-prescribe. Well, towards the end of this lecture, we'll do a full case of de-prescribing, and you'll see what I'm talking about. Sometimes less is more, and it's important that you guys take a minute to look at what we can take out of here for this patient medication. And then reconsider medication appropriateness late in life. What do I mean by this? So the best example that I can provide for you is, think about a patient that has 2 years of living left, 2 years max. And then he has high cholesterol, and you're gonna put him on a statin. Have you guys heard about statins? Well, the benefit of statins are not seen until 10 years. So why would you put the patient on there if they only really have 2 years left? So that's what I mean medication appropriateness later in life. Not all medications work right away. So what are the risks associated with high-risk medications? So again, adverse drug events, drug interactions, metabolic changes, and decreased clearance, especially in this population. So now let's move on and let's talk about some age-related changes in pharmacokinetics and pharmacodynamics. I know you guys are all experts at this, I've heard. So kinetics, what the body does to the drug, essentially. So we're going to talk about these 4 facets of pharmacokinetics: absorption, distribution, metabolism, and elimination, and how they are altered in the elderly. So let's talk about absorption. So in the elderly, gastric acid production is reduced. This is important for medications that need an acid environment in order for them to be absorbed and work. However, gastric emptying is prolonged. This is not clinically significant. It may actually be a good thing because it delays side effects, but it's not such a good thing for medications that cause ulceration of the GI lining, like aspirin or ibuprofen. They have slower liver blood flow or a slow first pass, and this could be a good thing and this could be a bad thing. Again, you have medications with certain properties that if you don't have a fast first pass effect or a high, then there are an increased risk for adverse effects because now they're lingering in the blood much more than they would have if they would have been cleared on that first pass or metabolized during that first pass. And then, although I didn't list it, the skin is also a facet of pharmacokinetics. In the elderly, there is reduced subcutaneous fat. And so when you apply medications topically, the fat acts as a reservoir for the drug to slowly deliver and have an effect. And they don't have that, so they're going to have increased risk of adverse effects. All right, so looking at distribution, in the elderly, we have a decrease in total body water, a decrease in lean body mass, as well as albumin and hepatic blood flow, as we mentioned. However, there's an increase in body fat, not subcutaneous, just body fat. So if there's a decreased total body water, what's going to happen, there's going to be a decreased distribution of hydrophilic drugs. What is hydrophilic drugs? Water-loving, water-soluble. Exactly. So this is where they distribute to your water-filled areas. And so if you have a decreased total body water, that means you have a higher concentration of the drug because it doesn't have as much place to go and distribute. And so because of this, hydrophilic medications need to be reduced in the elderly. And a perfect example of this is lithium. Now I have a question for you. How should the dose of a lipophilic drug, like diazepam, differ in a young versus an elderly patient? Should you reduce the dose, should you increase the dose, or should you keep it the same? It's a trick question.
Reduce.
I hear reduce over here.
I said reduce because they have more body fat.
Exactly.
And it's lipophilic, it loves fat.
Very good. So it's actually reduced. You have to reduce the dose. Why? Because there's more fat tissue, which means the drug is going to distribute. It's lipophilic, it loves fat. So it's going to go and distribute in the fat tissues. And so because of this, the half-life of the drug is going to be cranked up. It's going to be harder to get it out of the system. And so we have to also reduce lipophilic drugs in the elderly. And then we deal with decreased plasma albumin. So notorious drugs, warfarin and phenytoin. They're greater than 90% protein bound, And if you have if the patient has a decreased plasma albumin, there's more free drug, unbound, that's going to go and act. And so you're going to have high incidences of bleeding with warfarin or phenytoin toxicity. All right, so moving on to metabolism. Are you guys seeing my stars?
Yeah.
Okay.
Oh.
All right, let's see if you guys missed any. There you go. All right, so metabolism.
No, they're not.
So we have a decreased liver blood flow, which we mentioned, decreased liver mass. However, when it comes to metabolism, there's two major phases. Phase 1, which is your cytochrome P450, and then you have your phase 2. During the phase 1, this is where the phase that occurs more slowly in the elderly. So if you have medications that are metabolized through that phase, you have to think about those reductions potentially, or concomitant drug uses in this population. Then you have to determine, are you going to prescribe that, reduce that, or are you okay with that? Or you can just call your pharmacist. So diazepam, propranolol, and amitriptyline are some examples of drugs that can linger on longer because of decreased metabolism. And then phase 2, this is where you're dealing with glucuronidation, acetylation, etc. And thankfully, it's not much change in the elderly. And lorazepam and temazepam, benzodiazepines that are metabolized through this route. So if your patient ends up needing a benzodiazepine, these are probably the drugs that you want to choose because they'll be able to excrete them and metabolize them. All right, elimination. So there's decreased renal blood flow in the elderly. So that directly impacts glomerular filtration. That's also decreased. So between ages 25 and 85, there's a 50% decrease in glomerular filtration. And as we mentioned, they have decrease in lean body mass, but there's decreased muscle mass, which means there's decreased serum creatinine. Are you guys familiar with creatinine? Muscle breakdown product. So in a normal healthy adult, you're looking at around 0.6 to 1.2 milligrams per deciliter of serum creatinine reported. And when you measure this in an elderly, you'll see like 0.4, 0.3, like really low things. So serum creatinine alone is not a good indicator of renal function. Why? Because we estimate creatinine clearance in order to estimate renal function, in order to adjust medications appropriately. Did you guys go over Cough-Raff and Galt in pharmacokinetics work?
Sounds great.
Well, that's okay, we can go over it. I have a couple slides on it. So Cough-Raff and Galt is one of the most commonly used equations to estimate basically renal function by using creatinine and creatinine clearance to estimate this function. So you want to use this equation mostly in patients whose actual body weight is within 30% of the ideal body weight. If they exceed that, then you have to use their ideal body weight at that point. So what do I mean by this? Here's the equation. It takes into account the patient's age, weight in kilos, their serum creatinine reported, times 72, and then at the end of all this, if they're a female, you have to multiply it by 0.85 to account for the differences in the female. There are some rules. We can only use this in adults. They must have a stable serum creatinine throughout the day. The actual body weight in kilograms. And you have to be sure that they're not obese and not exceeding that 30% mark. And so the way you would do that is you would have to first figure out what their ideal body weight is. And there's a different formula for men and women. And then once you figure that out, then you divide actual body weight over ideal body weight and make sure it doesn't exceed 1.3. And there's the equation, okay? Now, I don't know, I heard someone say that you did hear this and you're familiar with it. There is some clinical controversy. As I mentioned just a couple minutes ago, serum creatinine is decreased in the elderly. And, let me go back for a minute. If the serum creatinine is low, the creatinine clearance result is going to be high. So it's an inverse relationship. So if an elderly has a serum creatinine that's lower than usual, their creatinine clearance, their estimation of renal function, is going to be reported as high or good. What's an average renal creatinine clearance function like an average in a healthy adult? Anybody know? It's 120 mLs per minute. Creatinine clearance, like for myself. And in an adult and an elderly who has a really low creatinine, and then you plug these values in, you can get a creatinine clearance of 120 or 130 or 140. That's bizarre. We know that their renal function is already compromised by that age. So their creatinine clearance is reported falsely elevated. So because of this, there are clinicians in practice that they will round the serum creatinine value either up to 1 or 0.8. There's no real consensus. So some people say if you round all the way, if their creatinine is 0.4 and you round it to 1 in order to calculate creatinine clearance, then they say, well, that will give a too low of a result of a creatinine clearance. So then someone say, well, we'll just do 0.8. It's better than 1, and it's not as low as their reported creatinine. So as I mentioned, rounding serum creatinine up equals a decrease in creatinine clearance, which will show a more appropriate representation of what their renal function is. When you're calculating this, you would never round down. If they have some sort of renal injury and their creatinine is 1.3, you would never say, oh, let me round it down to 1 if that's what you're going to do. So let's just do an example so that you guys can do it yourselves and see what you guys come up with. I have two here actually. I have a female and then a male. And I'll give you about 3 to 5 minutes to get this. If you have an answer, let me know. do you guys have some answers?
I have a question.
Sure.
The formulas for ideal body weight that you have up there, do they matter in either of these cases? Because both of them don't seem to be obese.
Then no, it wouldn't
Oh.
matter. Then you would use their actual body weight because it's not
Okay.
above. But you still have to check sometimes,
Sure.
because sometimes you don't know that off the top of your head. Here's some answers. Anybody want to share? I heard someone over there say the answer. Be confident. Tell me.
I didn't say that in the first question. Yeah. 54. Yeah, that's what I want.
All right, very good. All right, so if you use the patient's serum creatinine of 0.6 and you realize that they're a female, you should have gotten 54 mLs per minute. And just to show you what I mean with the differences in the clinical controversy with the serum creatinine, if you use 1, which I asked you to do in the problem, then the calculated creatinine clearance is 32.4. And if you use 0.8, then it's 40.5. You see how 0.8 is like right in the middle of the two, so people like to go with that consensus sometimes. But then you still have to like 1. This matters when you're dosing antibiotics in both ways. If you're looking at adverse effects, maybe you'll go with the lower creatinine clearance and adjust accordingly. But if you're looking at resistance, then maybe you might want to look at the higher creatinine clearance and dose it a little higher. So it just depends on what you're looking at. Case number 2, patient is an 81-year-old male weighing 105 pounds. When you plug everything, you should find 97.8 mLs per minute. You have to realize that you have to convert the pounds to kilos. Did you convert over?
Yeah. What is it? No, it's a man.
You don't want to get
What am I supposed to do?
0.8 pounds.
Okay, so 140 times 48.
What'd you get? 90. Maybe I rounded up. Depends on how well you rounded the pounds to kilos. That will. But you should have gotten anywhere between 98, 97, 98.
Yep. Okay. 28. Yeah. 47.
Did you all get how to do that?
72.
I think I just did the kilos.
Because I think there's a star somewhere.
I didn't use.
I think it's this one. So for your test, you will need to know the equation.
I don't have that.
You'll need to memorize the equation, but you'll just use the actual body weight for me. I won't have you calculate ideal body weight or anything. Here's the body weight that I give you. To calculate our creatinine clearance, just remember the formula. Alright, so just a recap. Recognize the gender when you're reading the problem. Circle it, highlight it, whatever you want to do with it. Convert the weights to kilos, and then in my case you won't have to worry about the weights, but just for learning purposes, don't forget about the 30% rule, then plug it in, and don't forget to multiply by 0.85 if it's female. Alright, we're going to switch gears. Did I scare you? It's going to be easy. It'll be easy, I promise. Alright. We use to calculate the ideal body weight?
Oh, that's the form.
That's the formula right here. For men, it's 50, and then 2 times, plus 2.3, because they're each about 5 feet, and then women is 45. That's amazing. But you won't have to do this test, but I felt like it's important for you to know when you have a really obese patient, then you definitely want to account for that obesity. And use the correct way, or else that's not creatinine. The Cockcroft and Gulf wasn't designed for obese patients. There are other calculators available if you don't feel like changing to like ideal body weight, such as the Salazar-Corcoran equation. It's just very complex and very hard to manipulate. So. All right, let's switch gears to pharmacodynamics. I only have 2 slides on this because you guys already covered it. So you guys are pretty good at this already. So the takeaway point when it comes to the elderly, they have diminished homeostatic responses. I listed some of there for you. I like to touch upon orthostatic blood pressure responses. So this is what happens. They have diminished baroreceptor response. And so when they get out of bed, their blood pressure plummets down and they are dizzy and they fall and then they have fractures. They also have changes in concentrations of drugs at receptor site, changes in receptor number and affinity, which will determine how they respond to the medication's effect, as well as changes in sensitivity of the tissues. So, this is the slide I want you guys to focus on. Alter sensitivities, the ones that are increased, benzodiazepines. You guys could hear about benzodiazepines. Not one of my favorite drugs for sure. Antipsychotics, anticoagulants, opioids. All these have an increased effect in the elderly. And then insulin and beta blockers tend to be decreased, so we usually need higher doses in order to get a good effect or a desired effect. All right, let's cover one more objective before we take a break. Let's discuss the Beers criteria and its implications on medication prescribing in the older people. That is not the beer on top. Sorry. No, not that one. Has anybody heard about beers?
Beer's law.
Not that one. So I'm talking about Mark Beers. So Mark Beers. The Beers criteria is a list of medications that is published by the American Geriatrics Society. And it's basically a list to help you guys and myself and any clinician help guide therapy in elderly and be able to choose wisely because they report all the potentially, not all, but the ones that they reach a consensus on, potentially inappropriate medications used in the older adults. I use this list a lot in practice. I'll tell you a story later. There's a pocket guide that you can download and you can take to your rotation sites. You guys start rotations soon? In a year? Yeah. That's pretty soon. Yeah. Pharmacy school went like this for me. So, I recommend and I really suggest that you download it, keep it with you on your laptop because you'll refer to it when it comes to prescribing. All right, so what's the goal of the Beers list? It's to improve the care of the older adults by reducing exposure to potentially inappropriate medications referred as PIN. So the Beers list is used both in the hospital as well as the ambulatory care setting, and it's designed to be used by us practitioners. However, they use this list in order to make policies in hospitals, for example. You could create restrictions when a medication is considered inappropriate. And so it's for patients greater than 65 years of age, and that's how we have defined elderly in this spectrum. All right, so it helps you improve selection, evaluate patterns of drug use, educate yourselves as well as patients, and evaluate health outcomes, quality of care, cost, and utilization. However, it's not designed to override your judgment. What do I mean by this? It does not talk about the use of appropriate medications when they're used inappropriately. So it doesn't help you in that sense. And it doesn't take the patient's factors into consideration. For example, if you have a patient that is going to have palliative care, they're dying soon, they're going to go to hospice, and the list says, don't use opioids in the elderly. Avoid. You know that in that scenario, you will use opioids. So you have to really think about the patient and not just this list. All right, so Mark Beers is the one that created it. And then, so he made up this panel of 11 experts in geriatric field in various settings. And it encompasses 53 meds or med classes. There's a mixture of both. And each med or med class has a recommendation and quality of evidence for each potentially inappropriate medication statement. It does exclude some exceptions when deemed appropriate by the panel. But then again, only by the panel. If they didn't reach that consensus, then it's not listed there. There's 3 categories. You have the first category, the potentially inappropriate meds to avoid in the elderly. You have the meds to avoid with certain disease states. And then you have the medications to use with caution. So you can use it, but be careful. And here's what the grading looks like. You have quality of evidence, and then you have strength of the recommendation. This is what you have to think about. If you're looking at this, and you have a quality of evidence low and a strength of recommendation insufficient, are you going to use that as your judgment? No, exactly. So, and the worst part is that it's a really tiny box in the list. Let me show you. So here's an example of disease specific. You have heart failure, and then it's going to list the drug that you should avoid in heart failure. So NSAIDs, COX inhibitors, calcium channel blockers, etc. And then here you have the strength of recommendation, the quality, and then the strength. So then here you have moderate, quality of evidence, and then strength, strong. So that's pretty good. I would like to follow that because it's good. So pioglitazone, we're not using heart failure. All right. So the main drugs that come to mind when I think about beers are listed here. Independent of disease, amitriptyline.
Like what is when it says more than 2 or equal to 2 RCTs?
Oh, that means more than 2 or equal to randomized controlled trials, which are the gold standard when evaluating literature. All right, so the independent, the drugs independent of disease states. Do you guys know what amitriptyline is? Have you heard of it? Yeah, it's an antidepressant. It's a tricyclic antidepressant. It's popular among elderly because before we had the new agents, the SSRIs or serotonin reuptake inhibitors, that's what they used to put patients on, TCAs. And so there's a lot of elderly patients that still use this, but we don't want to use it in the elderly, and I'll tell you why later. Benzodiazepines, diphenhydramine. What's the brand name for diphenhydramine? Benadryl. They buy that without your prescription. So think about that. Meperidine, opioid, NSAIDs. Can I get some examples of NSAIDs? Ibuprofen, naproxen, Mobic, and the methicillin. Perfect. Yeah, they're not very well accepted by peers. And then dependence of diagnosis. If you have a GI ulcer, you want to avoid NSAID, aspirin. If you have constipation, you want to avoid anticholinergics. What are opioids? Anticholinergics. What are anticholinergics? Have you guys covered that? I'll go over it later on. All right, so for incontinence, opioids, muscle relaxants, and then cognition, avoid benzos. So benzos everywhere. So why is this important? We talked about medication-related problems and how costly they are and how it can lead to poor outcomes and how a lot of these are actually preventable. And again, healthcare expenditures related to use of PINs totaled 7.2 billion. There is a strong correlation between abuse medications and poor outcomes in these patients. So overall, less is more. Don't be afraid to not prescribe or de-prescribe. And don't be afraid to try non-pharmacological therapies. All right, let's take a 10-minute break. Thank you, guys.